There you go.
So thanks for having me. My case presentation is a 62-year-old male that came to us with communication difficulties for about 4 years. His wife was very clear that it was a communication problem, not a memory problem. He did have decreased verbal output when he was speaking. And she says that he would just say things that didn't make sense. She reports behavioral changes as well, that he was more apathetic, not doing activities that he used to do, and lack of empathy. She was missing a part of their relationship that he used to be very present in. And he was pretty unaware of these behavioral changes, but he did not contest his wife's report. He was saying, if she says this is happening, this is what's happening. He did report vision changes, but he didn't elaborate much on that. He just says he doesn't see things the way that he used to. Walking was very rigid. He had increasing challenges with balance and was falling frequently without really noticing much change in his gait. He was seen by general neurology where he lived, and the medical record review showed that he was treated for vitamin B12 deficiency. It was an atypical Parkinsonism, but it was not responding to carbidopa, levodopa, 25/100, 2 tablets 3 times a day. They did perform neuropsychological testing, and it was classified as an unspecified dementia. So he was started on donepezil, titrated up to 10 milligrams without much of a response. The remainder of the neurology workup was negative, no family history of neurodegenerative disorders. His social history, he was retired from his state job. He was college educated, bachelor's degree, and he thought maybe the stress was causing his communication problems, so he retired early and took a job in a liquor store just to keep himself busy, but he was let go of that job due to inability to make change. I did not have his MRI films at the time of his evaluation, but of course you can read here that it doesn't seem very remarkable. Not much to say there, a few small vessel changes and otherwise unremarkable. Medications, again, nothing too exciting there, but what was interesting is he ran out of his donepezil about 3 weeks before seeing me, and his wife reported that he was clear without it. His physical exam did show this atypical Parkinsonism I referred to earlier. He had a flat affect, masked face, decreased blink reflex, limitations in vertical gaze. He had a dysphagia, but it wasn't necessarily dysarthric. He had an expressive aphasia with word finding difficulties, but he was hypophonic. He had normal muscle tone peripherally, but you could tell he had axial rigidity by the way he would move. He did have an endpoint tremor bilaterally, but no bradykinesia that we would expect. But I should say steady gait here, but he did have a decreased arm swing and an inability to tandem. And you would see some changes in his gait when he would be turning. There was difficulty with turning. His MoCA at the time was 24/30, so my working diagnosis was frontal temporal dementia or other frontal temporal dementia. I don't want to be too specific in the gate. But then the obvious happened. I got his MRI of the brain, and I think we could see here the hummingbird sign. So when I followed him up in telemedicine, which was just a few months later, wife did report a progression of symptoms. He was falling more. His apathy was worse. Wife actually had to leave him a list of things to do during the day while she was working. Balance was deteriorating, and I forgot to mention here, he actually started developing problems with swallowing. So we did talk about the diagnosis of progressive supranuclear palsy, and I referred him to palliative care. I don't see him in clinic any longer, but I do work with palliative care to support this patient. What we know about progressive supranuclear palsy is that it does affect men greater than women in about the 6th decade of life. It's uncommon, but not rare. I think it's more common than we originally thought. So a few years ago, and it is considered a pure tauopathy. So it's a good thing to study the anti-tau monoclonal antibodies, but unfortunately, the 2 that we know of failed phase 2 clinical trials. There are currently no FDA-approved medications to treat this condition, and treatment is supportive. So thank you for listening.
Great job, Michelle.
Thanks.
All right. For our grand round speaker, we're going to turn it over to Chris Eckstein for the introduction.
Good morning, everybody. So this week we'll be continuing to hear from some of our soon-to-be graduating chief residents. We started this a couple of weeks ago, and over the next several weeks, we'll hear from everyone else who's going to be finishing up this year. Today, we'll be hearing from Paul McIntosh. So Paul did his undergraduate medical school at UNC just across town. We were fortunate enough to steal him from UNC for residency. I've gotten to work with him quite a bit over the last 3 years. So I was just kind of thinking about this. I've been residency director just long enough to work with this group starting in their PGY2 year through this year. And so many of them, and Paul in particular, I find when I'm on service, I have to read quite a bit more because he's a never-ending wealth of obscure neurology facts and disorders that I feel like I've never heard of and have to go look up when he says them. So he's going to be headed up to Boston this next year for a neuromuscular fellowship, and I'm sure he's going to do well there. So Paul, I'll turn it over to you.
All right, thank you for the introduction, Dr. Eckstein. And so today I will be talking about some somewhat obscure neuromuscular conditions. And my talk today is neurology and Halloween, so it should be a fun talk. So some disclaimers before I get started. Any comparisons between fictional characters, logical conditions are made for learning purposes only. I myself have a neuromuscular disorder, and I'm not trying to poke fun at any neurological conditions. And one of the main reasons I chose this topic was so that I could shamelessly show photos of my beautiful wife, Wendy, and my cat, Taz. The picture on the left, Wendy's dressed as Edna Mode from The Incredibles, and I'm Mr. Incredible. And the picture on the right, Taz is dressed as Wonder Woman. So today we'll talk about vampires, werewolves, Frankenstein, and zombies. So let's get started with vampires. What do we know about vampires? Well, they demonstrate odd behavior. They are photosensitive and avoid daylight. They have fangs, and they are nourished by consuming blood. Could vampires have porphyria? Patients with porphyria can be encephalopathic. The deposition of porphyrins in the skin can cause extreme photosensitivity and light aversion. With repeated damage, the skin tightens and shrinks. And when this occurs around the mouth, the canine teeth can appear more prominent, suggestive of fangs. And there's symptomatic improvement with IV heman. All right, so here's an image reviewing the metabolic pathway of heme synthesis, including the intermediates, enzymes, and associated diseases. The diseases highlighted in yellow: acute intermittent porphyria, hereditary coproporphyria, and variegate porphyria, all have neurological manifestations. Acute intermittent porphyria is an autosomal dominant disorder with a prevalence of 1 in 10,000 to 1 in 100,000. And the clinical triad includes abdominal pain, psychiatric disturbance, and an acute motor predominant axonal neuropathy. Attacks of AIP typically begin with the abdominal pain, which is usually severe, often sufficient to require pain medications or to result in exploratory surgery. Triggers can include barbiturates and other enzyme-inducing anti-seizure medications, sulfa drugs, alcohol, and fasting, among other things. There are altered mental status and psychiatric manifestations that develop either in association with the abdominal pain or soon afterward are usually non-specific. Symptoms can include restlessness, insomnia, agitation, and hysterical behavior. A diagnosis of conversion disorder is frequently considered based on the severe abdominal pain in the setting of an unremarkable abdominal exam, in addition to the psychiatric features. About 1/3 of patients with AIP develop an acute motor predominant axonal neuropathy that characteristically affects the proximal muscles of the upper limbs, often asymmetrically. onset of the neuropathy after an attack of abdominal pain is sometimes delayed anywhere from 3 days to 75 days after an attack. And it usually, the neuropathy reaches maximum intensity at an average of 2 to 4 weeks. And the differential diagnosis of this axonal neuropathy includes the AMAN variant of Guillain-Barré syndrome and heavy metal intoxication. Diagnosis is made by urine studies. Urinary excretion of porphobilinogen is increased during attacks. Sometimes an elevated urobilinogen on a basic urinalysis can be a helpful clue. However, this compound is unstable, making this screening method unreliable. And once a patient is determined to have a substantial porphobilinogen elevation, the specific type of porphyria can be established by biochemical testing of the urine or plasma for aminolevulinic acid, porphobilinogen, and other porphyrin intermediates.
Hey, Paul, you're in the mode where you can see both the slides and the, oh, perfect. If you could, I think presentation mode just be a little bigger.
Okay. I thought you weren't able to see that. My apologies. Okay. So the treatment is with carbohydrate loading or IV hemin. They are both specific for the treatment as they downregulate delta aminolevulinic acid synthase. Glucose or carbohydrate loading can be used for mild attacks, where IV hemin is used for more severe attacks. And the prognosis is generally good. There's a rapid resolution of the abdominal pain and encephalopathy. However, the neuropathy resolves much more slowly and is dependent on the degree of axonal damage. Importantly, skin changes do not occur in AIP, thus vampires are unlikely to have AIP. Well, what about hereditary coproporphyria and variegate porphyria? So hereditary coproporphyria and variegate porphyria are both similar to AIP in their presentation. However, they both can be associated with skin photosensitivity. They're both less common than AIP. However, in certain people groups, they can have an increased prevalence. For example, variegate porphyria has a higher prevalence among white people of South African descent, with a prevalence of about 0.3%. However, the photosensitivity is relatively mild in these conditions and would not leave a person to be only out at night. Porphyria cutanea tarda is another type of porphyria that does have severe photosensitivity with blisters, scarring, and dark pigmentation of the skin. However, there are no neurological manifestations. So vampires might not have porphyria. So what could they have? Could they have lead poisoning? Lead poisoning can be viewed as an acquired porphyria. It has a lot of the same manifestations as acute intermittent porphyria, including abdominal pain and neurological manifestations such as encephalopathy and neuropathy. Patients also tend to have an anemia. In regards to the neurological manifestations in children, it's usually an encephalopathy, where in adults it's a neuropathy. And similar to acute intermittent porphyria, the neuropathy tends to be motor predominant. It also tends to involve the arms more than the legs, and it particularly involves the radial nerve or its branches like the posterior interosseous nerve, and it often is asymmetric. As you can see in this picture, Dracula has bilateral wrist drop. He could be pale due to his profound anemia, so I can only speculate that his coffin is lined with lead paint. So now we'll talk about werewolves. And this video is my cat Taz. She was dressed as Simba from The Lion King for Halloween, but she kind of looks like a werewolf. So this is a little bit of a stretch. Werewolves have a lot of hair, and hypertrichosis is seen in a few neurological conditions, notably the porphyrias, and also Poem syndrome. So Poem syndrome is a rare paraneoplastic syndrome that's due to a monoclonal plasma cell dyscrasia. And the key features of Poem syndrome are included in its name. polyneuropathy, organomegaly, endocrinopathy, monoclonal gammopathy, and skin changes. So here's a table of the key clinical features and the associated prevalences. I just wanted to point out that polyneuropathy and monoclonal plasma cell dyscrasias are universally present, where these other features are not always there. Interestingly, the SPEP is only positive in about 50% of cases. Here's my cat Taz, who wanted to join the talk today. Serum-free light chains can be elevated in about 70% or more patients. Otherwise, the presence of a monoclonal plasma cell dyscrasia is based off of bone marrow biopsy. In regards to the skin changes, patients tend to have hyperpigmentation of the skin and increased hair growth. This hypertrichosis involves the growth of long, coarse hair, typically in the extremities, sometimes along the trunk. There can also be skin thickening. Post-syndrome polyneuropathy, it's a demyelinating sensory motor neuropathy that begins distally in the bilateral legs, and it can progress rapidly to a polyradicular neuropathy, where patients can have quite severe sensory and motor loss. And the distal weakness can be so severe that they can have bilateral foot drop in addition to distal atrophy. There typically is not much autonomic involvement in POEM syndrome. And the most common diagnosis on the differential is CIDP, and up to about 60% of patients with POEM syndrome are initially diagnosed with CIDP. So apart from the presence of a monoclonal gammopathy, there are a few other features that can be helpful in distinguishing POEM syndrome from CIDP. One is patients with POEM syndrome are more likely to complain of severe pain. And on nerve conduction studies, they're more likely to have uniform slowing of their conduction velocities without conduction block. Both conditions can have high CSF protein. However, POEM syndrome can have an extremely elevated CSF protein. Also, patients with POEM syndrome have an elevated plasma over serum VEGF level. And POEM syndrome does not respond to typical CIDP therapies, which can be a helpful clue. Here's another table with some other features that are seen in POEM syndrome. For example, patients can have papilledema, evidence of volume overload, osteosclerotic bone lesions, thrombocytosis, and other features such as clubbing and pulmonary hypertension. Diagnostic criteria have been established. Patients have to have both of the major criteria, which includes the demyelinating polyneuropathy and the monoclonal plasma cell dyscrasia. They have to have one of the other major criteria, which includes Castleman's disease, the sclerotic bone lesions, and the elevated VEGF. And they have to have one of the 6 other minor criteria, which include the organomegaly, the evidence of volume overload, endocrinopathy, skin changes, papilledema, and thrombocytosis. So here's a picture of Frankenstein fighting a werewolf, and the werewolf is losing because of his profound weakness due to his POEM syndrome neuropathy. He can barely stand on his feet due to his severe distal bilateral lower extremity weakness. So now let's talk about Frankenstein. So here's a video of Frankenstein, and I want you to pay attention to his face. So from the video, we can see that Frankenstein has bilateral ptosis. It also appeared that he had facial diplegia. He moves slowly. He didn't speak in the video, but his voice is dysphonic, and he's status post major transplant surgery. So he could have post-transplant myasthenia gravis, as bone marrow transplantation is an iatrogenic cause for autoimmune myasthenia gravis as a manifestation of graft versus host disease. Other iatrogenic causes of myasthenia gravis include penicillamine and, more recently, the checkpoint inhibitors. Here's another video of Frankenstein. I want you to pay attention to his gait. It's clearly ataxic. He's bumping into objects. Maybe he's walking like this because he can't see well. It's because he's status post major transplantation, he might be on the root of all evil, tacrolimus. So could he have PRES, or posterior reversible encephalopathy syndrome? PRES is associated with tacrolimus and is clinically characterized by visual disturbance, headaches, confusion, and sometimes seizures. Radiographically, it's characterized by typically posterior, relatively symmetric T2 hyperintensities involving the subcortical white matter. Frankenstein's gait disturbance could be due to vision loss due to bilateral occipital lobe insults causing cortical blindness or Anton syndrome. Or if these lesions are slightly superior, affecting the parieto-occipital area bilaterally, you could have Balint syndrome. Balint syndrome is characterized by a triad of optic ataxia, ocular apraxia, and simultaneous agnosia. Optic ataxia is defined as difficulty using visual attention to guide extremity movements. Patients will have intact vision, however, they have issues using their vision to reach for objects. For example, on finger to nose testing, their movements appear misdirected, as if they just can't find where they're reaching for. They can't see where they're reaching for. However, their movements back their nose, which is not under visual guidance, is very fluid. Ocular apraxia is an inability to use visual attention to guide eye movements. So patients will be able to look left and look right on command. However, they have difficulty tracking objects or shifting their gaze between objects in their environment. And simultaneous agnosia is defined as the inability to use visual attention to survey a scene. Sometimes they lose the forest for the trees. So when patients are given an object or an image such as this to look at, they may only be able to see the small letters, the E's, which are the trees, but they cannot see the big letter, the S, which is the forest. Frankenstein's ataxia gait also could be due to PML, progressive multifocal leukoencephalopathy. It's associated with organ transplantation. I believe the prevalence is about 0.7%, and the mean onset of symptoms, timing of onset of symptoms after organ transplantation is, I believe it's 17 months. So some common symptoms in PML, which tend to present subacutely, include confusion and behavioral disturbance, weakness and sensory disturbance, ataxia, and issues with gaits and language deficits. Frankenstein definitely has behavioral disturbance, he has gait dysfunction, and he has language deficit. So he probably needs a workup for PML. So PML is diagnosed based on clinical presentation, the neuroimaging findings, and having a positive JC virus PCR in the CSF. In regards to the imaging findings, there are kind of large, typically subcortical T2 hyperintensities. They typically have a corresponding T1 hypointensity. And generally, there's no contrast enhancement. However, PML associated with natalizumab or Tisabri sometimes can have some contrast enhancement. In regards to the treatment, there isn't a specific treatment for transplant-associated PML. You can temporarily reduce the immunosuppression. However, this comes at an increased risk for potential graft-versus-host disease. So now let's talk about zombies. So I love my wife, but I found this picture of her. She was dressed as Darla from Finding Nemo. And she kind of looks like a zombie to me in this picture. And here's a picture of Dr. Bedlack, who is a very fashionable zombie. So what do I know about zombies? Zombies love brains. And Duke Neurology loves brains. So there's a lot of similarities between us and zombies. However, one difference is that zombies by nature are infectious. So this made me think of prion disease. There are three major types of prion disease. There's spontaneous or sporadic CJD, which is the most common type. There are genetic prion diseases, which includes several different conditions, but I wanted to focus on acquired prion disease. So Kuru was the first known kind of acquired prion disease, and the mechanism of disease was due to cannibalism among the Fore people of Papua New Guinea. There's been about close to 3,000 cases of Kuru since the 1950s, and a total population of the Fore people of about 36,000. Kuru causes a pure cerebellar syndrome, and Kuru, it means trembling, likely describing the tremor or ataxic movements these patients would have. Kuru has also been called laughing sickness or laughing disease in the past because of the pathological bursts of laughter that these patients could have. Interestingly, women and children were more likely than men to have Kuru, and that was because during ceremonies in which they ate the remains, including organs of their deceased relatives, women and children more likely would partake in that as a sign of respect than men would. This practice of cannibalism since has stopped. However, the incubation period of Kuru can be very prolonged. On average, it's 12 years, but it can be as prolonged as 50 years, so rare cases still may occur. And this brain up on the top left, we ate at a neurology party several years ago. It was a brain cake made by Eric Guglik's wife. Variant CJD, or mad cow disease, is another type of acquired prion disease. So how did this come about? Well, sheep have a prion disease called scrapie. Cows would eat whatever was fed to them, and cows developed bovine spongiform encephalopathy, or BSE. So now cows have a prion disease, humans eat what's ever packaged at the grocery store, and humans develop variant CJD. So the early clinical course of variant CJD is dominated by psychiatric symptoms, and after about 6 months, frank neurological signs developed that include ataxia, cognitive impairments, and abnormal movements, which can be creiform or myoclonic, sometimes dystonic. And the total disease course is typically 12 or 13 months before demise, which is several months longer than sporadic CJD. Here's a graph of the cases of bovine spongiform encephalopathy in blue in numbers of thousands, and in green are the number of cases of variant CJD. The peak BSE cases occurred around 1992 at close to 40,000, and the peak number of variant CJD cases occurred around 1999 at 30 cases. So compared to other prion diseases, in variant CJD, the prions are not only present in CNS, but they're also present in the lymphatic system. Therefore, tonsil biopsy can help be used in diagnosis. And based on anonymous tonsil and appendix biopsies in the UK, at least up to a few years ago, up to 1 in 2,000 people who lived in the UK during the early or the main days or years of this pandemic, the early 1990s, may harbor the latent variant CJD. Right now, it's kind of unclear how many of those people will develop variant CJD or when they will. However, it has been shown that variant CJD can be acquired through blood product transfusion. There's been about 3 cases of that. The recipients of the blood developed the symptoms of variant CJD about 6 or 7 years after the blood product transfusion. And the donors, they donated the blood several years before they developed any symptoms that could resemble variant CJD. It is for this reason that the United States don't allow anyone to donate blood here that lived in the UK or other BSE affected regions in the early 1990s for this potential complication. And additionally, a lot of the blood products in the UK are derived from donors from the United States. Chronic wasting disease is another form of acquired prion disease. It affects deer, elk, and moose. Thankfully, it's not very prevalent in the Southeast. It is much more prevalent in Western United States. And studies have not shown that chronic wasting disease is transmissible to humans yet. So prion disease is terrifying. It got me thinking, what other infections could cause the zombie apocalypse? And I thought of rabies. It's a single-stranded RNA virus. Thankfully, in the United States, it's quite rare with less than 5 cases per year. And in the United States, the most common vectors are coyotes, foxes, bats, skunks, and raccoons. However, in the developing world, particularly in Africa, it's much more common. And it is the most common viral encephalitis in many parts of Africa. And the vector in Africa, or the animal host, is dogs. And these are 2 dogs that Wendy and I fostered during COVID. To the left, that little puppy, his name was Cooper. And to the right, the older dog, her name was Hallie. Hallie was not very menacing because she was missing some teeth. But if she had teeth and had rabies, the initial symptoms typically are pain and paresthesias at the site of inoculation. Following that, the rabies virus replicates locally in muscles and peripheral nerves and cytoplasmic inclusions called Negri bodies before it utilizes a host machinery to make its way up towards the cortex, where it tends to cause a basically uniformly fatal encephalitis, and that's called the furious form of rabies. So there's 2 forms of rabies. The furious form, which I mentioned, is the most common form. And this is a form that has the characteristic symptoms we think of rabies: the hydrophobia, aerophobia, the agitated behavior, and there's a rapid decline and death within a few days. The paralytic form is less common, and it takes a much slower course. It begins with slow paralysis of the bitten limb, and over time, it progresses to complete paralysis, coma, and death. Human-to-human transmission through bites or saliva is theoretically possible, but it's never been confirmed. And the issues from a zombie standpoint for rabies is that rabies virus is essentially universally fatal. Additionally, rabies is 100% preventable with vaccinations of domestic animals, dogs in the United States. And there's also pre-exposure and post-exposure prophylaxis for humans. So far we talked about potential infectious causes of zombies. However, there have already been a few zombie outbreaks in the United States. So in Miami, Florida, in May 2018, there was a reported zombie attack. Some of you might have heard of this. It was due to bath salts. So what are bath salts? They're not what you put in your bath. They are synthetic cannabinoids. Canthanone is a psychostimulant that's found in the cod plant, which is native to parts of Africa in the Arabian Peninsula. And it has various modes of ingestion, inhalation, swallowing, things like that. And its effect is similar to amphetamines. It causes agitation and excited delirium, psychosis. Notably, bath salts are not tested for on the typical conventional drug screening assays. But prior to this, in Brooklyn, New York, there was a reported zombie outbreak in July 2016. It was due to a synthetic cannabinoid called amphetamine, and this neighborhood in Brooklyn was referred to as Zombieland. So there's a herbal incense product containing the synthetic cannabinoid, the amphetamine, and this herbal incense product was called AK-47 24 karat gold. And it caused a very strong depressant effect. And this accounted for the zombie-like behavior reported in the mass intoxication. Here is a graph or an image from that New England Journal of Medicine article that kind of just detailed the collaborative efforts in terms of figuring out what caused this outbreak. So it started July 12th when several patients in one local community presented to the emergency department. A lot of testing was sent to the UCSF lab for additional studies. The local police department was involved. The DA was involved, as was the Department of Homeland Security. As I mentioned, patient biological samples were sent to UCSF for analysis by mass spectrometry. The New York Police Department also obtained substances that these patients had used and sent those substances to UCSF as well for analysis. And amphibinaco was found in both products. So after spending about 2 weeks, the outbreak was resolved, and we realized exactly what the cause for the outbreak was. So in summary, today we talked about vampires, werewolves, Frankenstein, and zombies. Vampires could have porphyria or lead poisoning. Werewolves could have Poem syndrome. Frankenstein could have post-transplant myasthenia or an ataxic gait due to PRES or PML. And zombies could be due to prion disease, rabies, and various intoxications. So I just wanted to thank my friends and my colleagues who have been a tremendous support for me over the years. This is a picture a couple of years ago from the McIntosh Monster Mash, which is an annual Halloween party that COVID slightly messed up. But in this picture, there are a lot of residents. See, there's Ryan Gesser in the bottom left. Kind of middle left is Ben Groves. Bottom middle is Ryan Gustani. This was when he was a jar, and he dressed as the scariest thing that he could think of, which was a stroke code. Wendy, my wife, is kind of right behind him. Behind her, in the middle of the picture, is Sharina, who was an epilepsy fellow at the time and a former resident. Beside her to the left is Ovi. He was dressed as a bull. I'm to the left beside Ovi. I was Rafiki from The Lion King. And kind of behind me to the right is Nate, and he was dressed as Aladdin. And I also wanted to thank my very loving wife, Wendy, who's been a tremendous support for me over the years. I really couldn't have gotten through residency without her. One of the reasons we both like Halloween is because we met on Halloween. And the picture on the top left is actually the night that we met. I was wearing a football shoulder pads, jersey, and helmets, in addition to fairy wings and a tutu. So I was dressed as fantasy football. And Wendy, she was dressed in a chef's costume with a chemical symbol FE. So she was Iron Chef. So we both like Halloween, we both like puns. And over the years, we've typically done costumes, couple costumes. In the top middle, again, is a picture of her being Edna Mode and meeting Mr. Incredible from The Incredibles. The top right picture, I was dressed as Superman or Clark Kent. Wendy, she's my biggest weakness, which is kryptonite. And Taz was dressed as Wonder Woman. In the bottom left, it was the Lion King theme. So I was Rafiki, Taz was Simba, and Wendy was Scar. And in the bottom middle and the bottom right was this past year, we dressed up as Guardians of the Galaxy, where I was Star-Lord, Wendy was Gamora, and Taz was Rocket the Raccoon, and she had a little baby Groot on her back. So here are my resources. The top one, The Pearls and Pitfalls in the Horror Cinema, is an article I got a lot of inspiration from. It was a very fun read. And with that, I'll end, and I'm happy to answer any questions and I'm happy to take any suggestions for my cat's next Halloween costume.
Thank you, Paul. The first question is from Don Sanders. He wanted to know, does garlic affect porphyria?
So I looked into that briefly, and I think at high doses, it can increase heme synthesis, therefore causing worsened symptoms of porphyria or an attack, but it seemed like it was at more than physiological dosings. So there may be some truth behind it.
I have a question. Did you consider including the MPTP poisoning and the kind of zombie
Or
Parkinsonians?
I thought about
as one of
that,
your
and
cases.
I also thought about how I talked about this with Dr. Belak too, and in Haiti, the witch doctors had a ritual of bringing people back to life, and I believe they gave those people a mixture of like a potion that included tetrodotoxin, which caused them to look like they were dead. The patients would then get buried, and then over hours to days, when the toxin wore off, the patients would come back to life, and they would, quote, be
Well, at least
reanimated.
50% maybe.
Yeah, but they probably had traumatic or hypoxic ischemic brain injury, so they weren't quite themselves, and they were somewhat zombie-like.
Great. All right. Any other questions for Paul? Or I should look to see if there are any hand raised. All right. If there are a bunch of awesomes, Paul, coming in, but I don't see any other questions. So
Any suggestions for my cat's Halloween costume? No, okay.
should have something to do with the vaccine, don't you think?
Maybe, yeah. She doesn't mind dressing up. She just doesn't really like things on her head. I had to condition her over several months to like that, where I would put on her head, then feed her every night. So it took some training.
Oh, here's one, Pikachu.
Okay. Yeah, a current thought is maybe doing Pokemon themed, where Wendy and I are Team Rocket and Taz is the cat Pokemon Meowth, but maybe we could do Pikachu.
All right, everybody. Thank you very much, Paul, and best of luck.
All right, thank you.